Good evening to everyone, and thank you so much for taking time out of your evening to spend together, and hopefully this will be worthwhile and we'll get a lot of good information on overactive bladder. So as was mentioned in the intro, I've been in Georgia urology now for 7+ years, and I do practice general urology, but one of the things I'm passionate about is bladder dysfunction and how to help people who often feel like there may not be an option for them. So let's get right into it. So many of you could be identifying and might be identifying with some of these things that you're seeing popping up on the screen. Now that society is somewhat back to normal, we want to get back to a normal life. And are you able to go outdoors? Are you able to leave home? Are you able to visit family? And more important than whether or not you have these things is that oftentimes people are too embarrassed to talk about it. And in fact, we know that about half the people with incontinence haven't ever discussed it with their primary doctor. And the theme of tonight's talk is try to change that. So I call this, live without limits. And here's the things we're going to be talking about tonight. Number one is just to understand how the bladder works and some of the problems that can occur. Number two, we're going to focus on overactive bladder and some of the treatment options. And number three is I wanted to specifically focus on some of the lesser known options and give more detail about the ways in which we can treat these. And as was mentioned at the beginning, there's an opportunity throughout the talk to ask questions. These will be anonymous, and I'll try to address all of them at the end. So what you need to know is that you are not alone. Overactive bladder, or OAB, as I'll sometimes refer to it, is extremely common. This represents almost 40 million people. It's more prevalent, as you see from this slide, than diabetes. And if you add into that the fact that 1 in 12 individuals has FI, which is fecal incontinence, or incontinence has to do with the GI tract, you have another 20 million people. So this is obviously very common. And you'd be asking, if it's so common, why haven't you heard about it? And I just would remind you of what I said on the previous slide, which is embarrassment. People are embarrassed and oftentimes end up treating and end up trying different strategies, not going out, not getting together with family, not visiting children or grandchildren. And oftentimes this can lead to, as it says on the slide, loss of confidence, loss of self-esteem, and in general, poor feeling. So what's really important is that incontinence is not a normal part of aging or something that you just have to live with. It could be a serious health issue. And some of these, again, may be familiar, right? Going frequently to the bathroom, having that sudden urge to go where you're sitting and wanted to enjoy an activity and you have to go right then and there, and it sort of hits you. And oftentimes you may not make it in time and you may have an accident. Having to do what's called bathroom mapping. You go to the grocery store or you go out somewhere and you sort of have to be keenly aware of where all the bathrooms are. And that's just not something that you should have to deal with. And when you have some of these symptoms, I think it's important to recognize that your body is trying to tell you something, and it's important to then listen to your body. So let's start with just understanding the process here. And this is not a complicated slide, but I want to take you through it one by one. So you have to understand that the way the bladder functions, although we often take it for granted, is that there is a pretty complicated connection between the muscle of the bladder and the nerves of the body. And what we start with here in the middle of the slide is that the kidneys, which are shown in the middle of this individual, are producing the urine and they send it to the bladder. Now, when the bladder starts to get full, it stimulates nerve, which then communicate with the brain. And it tells the brain that it's time for your bladder to empty. And then the nerves from your brain then tell your bladder, okay, now I want to squeeze. And what's important is that this bladder-brain communication is really essential for bladder control. And the flip side of that is when there's a breakdown in this communication, it can result in bladder control problems. And wanted to sort of remember this about bladder brain, because there are different ways in which we can address the issues. And some of them work just on the bladder, and some of them work on this communication. And we'll get into that more as we go. I don't want to go too much on this slide, but as I mentioned before, about 20 million people have FI or fecal incontinence. And I bring this up because it's a very similar mechanism with the digestive system, where the colon feels full, it signals the brain signals back to the colon that it's time to go. And the reason I bring this up is the communication that often goes awry with the bladder is the same process, and actually the same nerve roots that have to do with bowel control. So where do these communications problems come from? Why does it happen? So there are a lot of potential causes. Some of them are as simple as what you eat and what you drink. Some of them can be the medications you take. And some of them have to do with life events like childbirth and other health conditions. And some of it could be pelvic floor dysfunction, which is often an underutilized and under-realized avenue to treat. So in general, there are three common problems that can take place in the bladder. There's stress incontinence, there's urinary retention, and there's overactive bladder. And we're going to take a closer look at each of them in turn. But again, for tonight, the goal is to really focus on number 3, which is overactive bladder, whether or not you also have leakage of urine or urgent incontinence along with that. So starting with stress incontinence, this is really something that has to do with leakage, which is an involuntary loss of urine during physical activities. It can occur sneezing, exercising, lifting something heavy. And this is really due to a weakened pelvic floor muscle, and Kegel exercises are sometimes used. And often, if that's not enough, surgery, outpatient setting is enough to correct this. But again, not going to focus too much on stress incontinence for tonight. Urinary retention is when you may also have an abnormal communication between the brain and the bladder, where the brain is not aware that the bladder is full, or it can't signal the bladder muscles to go, or the bladder muscles are just weakened. So you end up with a very full bladder that you may be unable to empty. You may have a weak stream, it may dribble. Sometimes people need a catheter. And this can be due to either an obstructive process, if there's a blockage in the system where you can't go. But the most common would just sort of be a non-obstructive retention, where the muscles of the bladder get weakened, or again, the communication is just not there between the brain and the bladder. So now let's focus on sort of what I think the heart of the issue is, and that is overactive bladder. So I think it's important. Often patients ask, what's the diagnosis of overactive bladder, and think that it sort of talks about a specific etiology. And it really doesn't necessarily have to do with one specific cause. But what I explain to patients is that it's really defined by a constellation or a set of symptoms. And those symptoms include urgency, so that immediate need to go to the bathroom, frequency, which is going to the bathroom often. It could include nighttime urination. So when you go to sleep and you find that between going to sleep and waking in the morning, there are several times that you're waking up to empty your bladder. And it can also be incontinence. So I wanted to sort of subcategorize this as urge incontinence, which is what's shown here. And also urgency frequency, which is going more than 8 times during the day, this uncontrollable urge to go that may not be associated with incontinence. But really both of these, from my perspective and in my mind, really fall under the umbrella of overactive bladder. So there are a number of steps in finding the best treatment. And I want to just say that I'm going to go through this pathway, but you have to individualize. And that's sort of the art of medicine. This is how I generally approach it. But sometimes patients come in where they've already tried and failed one of the options, or for a variety of reasons, they don't want to take more medicines, or they're not willing to undergo lifestyle changes. So really, it's going to be individualized to you. But when you look at this, what we have here is I want to separate into first, second, and third line treatments. So first line treatments are things like lifestyle changes. Second line, and I'll go into that. I'm not going to leave it with that. Second line is oral medication, so daily pills that you take. And then the third line, as I said in the introduction, is I really want to hone in on that, because there are very successful and non-invasive options that unfortunately are underutilized. And part of that is just from a lack of awareness from the patient perspective. So hopefully we'll change that tonight. So what are the lifestyle changes? Sometimes it could be weight loss or exercise. Sometimes it could be bladder retraining. There are different muscle therapies that you can do with a physical therapist who specializes in the pelvic floor. So unlike, I would say, traditional physical therapy, who work after an injury and work to regain strength, sometimes this is due to the pelvic floor muscle. Those are the muscles that support the bladder and the bowel. And if that is uncoordinated or discoordinated and constantly in a state of contraction, that can result in a lot of symptoms. So this would actually be physical therapy to help relax those muscles. And certain things you could do yourself, urge suppression techniques when you feel that urge, different breathing therapies you can do to sort of tell the brain, I know I'm not ready to go to the bathroom yet, and sort of retrain the bladder. So I would call this bladder retraining broadly. In some cases it works, and sometimes it may not work at all. So moving on to second line, when these lifestyle changes don't work or a patient's not willing to undergo, is overactive bladder medications. There are a lot of medicines, Ditropan, Detrol, Toviaz, Vesicur, Cinctura, Mirabetriq. These are just some of the names. Those are the branded names, but a lot of them, and most of them, are generic. And these can help control the symptoms. These work directly on the bladder muscle, either with relaxing the bladder muscle and increasing the relaxation, or decreasing the contraction, or the contractility, it's called, of the bladder muscle. So unlike some of the things we'll get to, which deal with the communication breakdown, these deal directly on the bladder muscle. The problem is that either the medications don't work, or it becomes a nuisance to take a pill every day. And unfortunately, although some of the newer medications have a, I would say, more favorable side effect profile, clearly these do have some unpleasant side effects: dry mouth, dry eyes, constipation, or with the older medications. Some of the newer ones, which are Mirabetriq, which the brand generic is Mirabegron, or Gemtesa, which is Vibegron, that can have some hypertension, but again, it's a daily pill. And what I wanted to highlight here is that due to the variety of reasons I mentioned, almost 3/4 of people stop taking a bladder medication within 6 months. So clearly, whether or not they lose efficacy or the patient is just not interested, that is an issue. So moving on to what I had as the third line therapies. This is for someone who either cannot get a good enough result, a satisfactory result, with first or second line, or someone who just does not want to take medication every day or has a side effect. And there's two main categories. And in the second category, there are multiple options. So the first category is Botox, which is an injectable medication similar to what some people get either for migraines or cosmetically injected. It's the same exact chemical. And the second category is called sacral neuromodulation. And that is really getting to the core problem, as opposed to just a Band-Aid with fixing the muscle. This is really trying to get that brain and bladder communication to be in sync, and to stop some of those bad signals that may be send from the brain to the bladder, giving you that sudden urge that you're experiencing. And both of these have trade-offs and their pros and cons, and we'll get into some of that. In terms of the neuromodulation, there are different ways in which that nerve pathway can be regulated. And again, we'll get into each of those in the coming slides. So moving on to Botox, this is a medication which is injected. It's FDA approved for overactive bladder. It's injected into the bladder. It's often done in an office setting, so it does not require general anesthesia. Usually we give a local anesthesia, so lidocaine into the bladder. The procedure itself takes 10 minutes. It usually kicks in within 2 weeks. So those are all obviously, I think, positives, and this is a great treatment for the appropriate patient. But what are some of the downsides? Some of the downsides is that this is a temporary solution. So even if it works perfectly, it needs to be repeated on average every 6 months. There's about a 5 to 7% risk that I quote to patients of a urinary tract infection or UTI. And there's also a 5 to 7% risk of need for catheterization. Well, why is that? The reason is the way this medication works is by relaxing the muscle of the bladder and sort of making it sleepy and partially paralyzed. And if it works too well, although it's temporary and will wear off, there may be a period of time where the patient will need a catheterization. So for patients who either because of their dexterity cannot do it or unwilling to have that risk, this is obviously not an option. And I think because of that, what we know is about half of patients stop after 2 treatments for these reasons that I mentioned before. Moving on now to the neuromodulation. So the first one I just want to mention is PTNS, or here PTNM, which is the tibial nerve modulation or posterior tibial nerve stimulation. And I wanted to show this picture because you may be looking at that ankle with an acupuncture needle and saying, what does that have to do with the bladder? So interestingly, as you can see in this diagram, I'm gonna try to put my mouse over it. The nerve roots, which are up here, which go to the bladder and the bowel, also have nerves that come out of the same exact root, which go down the back of the leg and end up by the ankle. So whether or not you regulate the nerve or modulate the nerve by stimulating it up in the lower back or in the ankle, you're really doing the same thing. So this is an option for people who want to not have anything ever implanted to them, nothing in the hospital. This is often done in the office. It is done in the office. It takes about 30 minutes. The initial induction of the treatment is 12 weeks. So it's weekly for 12 weeks and then monthly sessions. But that does mean that there is a tremendous time commitment and burden on the patient's perspective and from the patient's vantage point, that you're coming in every week for up to 12 weeks to have this done. And now let's get to INTERSTIM, which is something that that I think people don't know enough about, and hopefully again we can change that tonight. So this is a stimulation to those same sacral nerve roots, but it's done up in the lower back. And what ends up happening is a implantable wire goes in that sits right alongside the nerve that goes to the bowel and the bladder. And it gives constant, gentle stimulation to that nerve. And the way sometimes the nerves in the body work is if they become dysregulated, by giving a constant, steady pulse, it actually helps to re-regulate those nerves. And that's the presumed, I should say, pathway of how this works. But what I think is really nice about this option is it really, there's a test which I'm gonna mention, which can be done in the office before a patient has to even commit to this. A couple of things that I wanted to sort of highlight about this therapy. The batteries are quite small. The two images you see there are the recharge free and the rechargeable. So the smaller one is the rechargeable one. The recharge free has a battery lifespan of 10 to 15 years. And when it needs to be changed, it can be changed in the office. So we're not talking about something which is changed often. Also want to highlight that the battery itself, as well as the wire, are completely MRI compatible. So that used to be a problem for full body MRIs. That is no longer a problem. And also I mentioned that it stimulates the nerve. This is not something which the patient is going to be feeling routinely. This is not something that you're even aware of. It's almost a set it and forget it sort of pathway. So this is what the test is, and this is done in the office, and it really allows you to try it first, and it's almost like a test run. It's not a long-term commitment. It takes 10 minutes. What we do is you come in to the office, you're on your abdomen. I use lidocaine, or who your provider who's doing it would use lidocaine to numb the skin. A tiny temporary wire is then placed that goes to the nerve root. That is now attached to an external battery, which you can see in this picture. Kind of like if anyone's ever had a Holter monitor for the heart, there's a band that goes around the waist, and it holds the battery in place, and it allows you, or with communication with the representative or with my office, allows you to adjust it and regulate and change the program, change the power. And over a 3 to 5 day period, it gives you that amount of time to sort of figure out, with the regulation of the nerve, does it work? And we track your symptoms every day. And I've had, when it works, and it works, I would say in the high 80% of the time, patients who are waking up 3 to 4 times a night may call the next day and say, oh my God, I slept through the night. This was amazing. This is a game changer. And that's not to say everyone has that immediate result and that degree of resolution. But when it works, and again, that's a high percentage of the time, patients often refer to this as almost a miracle. And unlike the medications and unlike the Botox, this is really working with that communication as opposed to just the nerves in the bladder. So as I mentioned, this is both safe and effective. It's what it has here is about 3/4 of people, 76%, have success. Success does not mean that you go from wearing 5 pads to being bone dry, or you go from waking up every hour to sleeping through the night. Clinical success is measured as a greater than 50% improvement. But that number is chosen because people who have a greater than 50% improvement generally report a significant improvement in their quality of life. And there's about an 85% satisfaction among those who use it. Obviously, this is all comers. Individual providers have their own numbers, which can often be higher than this. So what makes someone a good candidate for this therapy? I would say when I talk to patients, I never talk immediately to third-line therapies, whether it's Botox, which I do a lot of, or INTERSTIM, which I do a lot of. It really is tailored to the patient. So if the patient has significant overactive bladder, OAB symptoms, or fecal incontinence, even in the absence of bladder incontinence, if someone has tried lifestyle changes, tried medications, they're not working, and they really want relief because they just don't want to live this way, and nor should they have to, this may be right. And I think it's nice to have options. And if this sounds like your experience, I think the first step is to call your provider, make an appointment. If you have not gone through the conservative steps, I would go through those first. If you have, we can set up that in-office nerve test. and really find something that works for you and helps you get resolution so you can really, as I said at the beginning, sort of get back to life. So with that, that's the last slide on the that I have. This is my office number, and there are 5 providers there. I focus on overactive bladder, as I mentioned before. This is in Fayetteville, Georgia. There's also a Medtronic website, which is medtronic.com/bladder specialist, where you can find providers who specialize in this. I'd love to see you in the office, or I'd love for you to follow up with your provider, whether it's with us or elsewhere. My focus is that you get the care that you need and you get the resolutions that you want. So again, thank you very much for your time. I don't take that for granted, and I really appreciate it. And with that, I'm going to now open to some of the questions that came in.